Yeah, it's also known as APRV. If you ever want to really read anything about it, you want to search for the name Dr. Habashi from shock trauma. He's like written everything there is to write about it. And he uses it. He uses it like all the time in shock trauma. They just put all their patients on APRV and Bivent. So kind of interesting. All right, so the way it's different is that I set 2 pressure levels. The patient can breathe above them. It's basically 2 levels of CPAP that just cycle back and forth based on the time that I've set. So I have a time at T high and then a much shorter time at T low. But this change, and I'll stop breathing so you can see what it looks like without that. It's going to maintain this pressure, drop down, and this is when I get gas exchange. This is when my CO2 will clear, okay? And then it goes right back up again. So ideally, it's used to keep the lung from deflating completely, right? So you use it to keep the lung recruited, keep it open a little bit so you have better compliance, better gas exchange. Works really great. It's a really good mode. And you don't have to sedate the patient as much because they're allowed to breathe as long as I do this. Okay, they're allowed to breathe over the vent, right? And then comfortable. It's just like breathing on CPAP, which is pretty easy to do. So it's a nice mode, but really has specific uses for hypoxic respiratory failure, hypoxemic respiratory failure, whatever. Low PF ratios. If that doesn't work, then ECMO is pretty much what we consider. So pretty much. Because if they're not recruitable, there's not much else you can do. PaO2 to FiO2. I talked to you guys about the ratio, and it's just your PaO2 divided by the FiO2, which is always 0.5 or 0.7 or point whatever. Our favorite FiO2 is either 100 or 50, because then I can just multiply by 2, or I don't have to do anything. If I'm on 100%, my PF ratio is whatever my PaO2 is, right? If you don't really know what it should be, just keep in mind a nice little ratio. We breathe 21%, and normal PaO2 is 100, right? Normal PaO2 is 100, yes? Good. So that's a 1 to 5 ratio, right? Whatever FiO2 I'm on, if I'm on 40%, my PaO2 could be as high as 200. If I'm 50%, it could be as high as 250. So you get a blood gas on somebody who's on 50%, and it comes back 85. And you're like, oh, that's not so bad. Well, it is. It could be 250. So what it should be if I had good normal gas exchange and normal physiology. Just kind of remember that 1 to 5 ratio, so you don't actually have to do the PF calculation if you don't want to. You just get a good impression for like, whoa, this guy should have a much higher PO2 than this. I'm not really concerned because it's 85, but do we need to do something more? Does that guy need maybe a little bit more PEEP instead of being on so much FiO2? So that kind of thing can just think about it. It's kind of like thinking about how much are they breathing to get that normal CO2? How much work is involved in that? Just things to remember. Okay, oh, and that's a picture by Little. All right, so these pictures on the ventilator. This value right here, this peak inspiratory pressure, is an important one to know. It basically is just how much pressure is it taking to deliver that breath to the patient. As long as it's less than 30, as a nurse, don't worry about it, okay? If it's greater than 30, you might want to talk to somebody about it, because if it's greater than 30, your plateau pressure, which is a measure that we do every 4 hours or when we do our vent checks, and anybody who's in assist control mode will do a plateau pressure. And that plateau pressure needs to be less than 30 to 35. So if my peak pressure is greater than 30, my plateau pressure is going to be around that. So I want to make sure it's never going to be higher than my peak pressure. But I want, if it's 30 or above, you can actually cause what's called volume trauma, which is when you're over-distending the lung tissue. And that over-distension causes the release of intracellular chemical mediators, tubular necrosis factor 6, 8, 10, interleukin 6, 8, and 10, tubular necrosis factor 8. Anyway, they get out and they cause trouble. Sorry. They can just call me back. And it releases, anyway, releases those inflammatory mediators that get into the bloodstream. A lot of the blood goes by the lungs, if we're lucky, right? And it goes out into the body. And it causes little microclots, and it leads to multi-system organ failure. So just by overstretching the lung or overventilating the lung and not protecting our lung, we can actually cause multi-system organ failure, because it releases those little teeny blood clots all around. It gets to be quite a mess. So if your pressures are higher than 30, ask the therapist, what are his plateau pressures? Okay, the new range is about 30 to 35, anything above 35 for a plateau pressure, okay? is dangerous for the lung. In an asthmatic, this could be 50, and my plateau pressure might be 20, all right? That's fine, but anytime it's over 30 to 35, you really want to know what the plateau pressure is. Just ask them, because we want to make sure, do I need to bring my tidal volume down? Do I need to do other things for the patient? Because you got to protect the lung, protect the lung, protect the lung. All right, so that's your peak inspiratory pressure, and that's what you need to know about. Your mean airway pressure is the one right next to it. It's kind of like mean arterial pressure. We call it mean airway pressure. If I want to improve oxygenation, that's one of the numbers I want to tweak. So I increase my mean airway pressure. I can do that by adjusting my I time, or my peak level. Those are the main ways to do it. Larger tidal volumes, of course, would do it, but larger tidal volumes are a bad thing. Who's been a nurse longer than 15 years? Nobody? Nobody's in here been longer than 15 years? Really? Oh, all right. Do you remember when we used to set tidal volumes at 12 mLs per kilo? Really big. And sometimes we didn't calculate predicted body weight. We just did 12 of actual body weight. I mean, my gosh, the amount of volume we were putting in these people's lungs, and we didn't know. It was the current state of the art for practicing medicine. In the 80s, when I worked at hospital center, my God, we would have trauma patients, their pressures were at 100, their plateau pressures are 80. We didn't know. You know, we had 20 a peak, 25 a peak, all kinds of crazy numbers. Because we just didn't know, because we wanted those normal blood gases, darn it. Okay. So it's the practice of medicine, so we keep practicing it. But tidal volumes now, we know it's very dangerous to do anything more than 8. There was a study that came out, I think, end of 2017 that said for every milliliter per kilo of predicted body weight greater than 6, you're actually increasing the likelihood of death. So we use 8 as a default still because people get air hungry on 8 as it is. But if their PF ratio is less than 300, then we will switch them down to 6 because 6 is actually the newest, it's really the safer tidal volume range, which is a big change for a lot of people, but not you guys because you haven't been practicing long enough to know. Just trust me, it's a big change for some of us. Anyway, but safer for the patient. So 8, so 6, 8 was the new 12, right? And now 6 is the new 8. Now it's 6, it's everything is changing now. All right, and your PEEP you guys know about. Total rate versus set rate. Right now it's the same because I'm not breathing over the vent, but this number here versus this number here, okay? I have an F oxygen here and I've got an oxygen here. This one green is being analyzed, all right? This is here is what is set. Why do I point this out to you guys? You guys all know the oxygen breath button, yes? It gives you 100% for how long? You fail. 1 minute. Only 1 minute, okay? And you know, the minute I hit that button, this changes to 100. This will take a few breaths to get up to 100, all right? Look here, and you'll know whether or not you hit it, okay? Because sometimes you might think you hit it, and you're not sure if you hit it. So you hit it again, and then it goes right back down to what it was before. So just hit the button and look here, all right? Should change to 100 right away. If it does, it'll give you 100 for 1 minute only. So if you have a patient who requires more than 60% oxygen and you're going to turn him, call your friendly respiratory therapist in there, and they can monitor the airway while you're turning, and they can turn the ventilator up to 100% while you're turning because it is far easier to prevent somebody from desatting during a turn than it is to fix it after they've desatted, okay? So if we can just put them on 100 for the turn, get them stabilized, they can watch the airway. Anybody on more than 60%, you're going to want to get some extra help in there for a turn. Do that, and then when the turn is done, we can stabilize him, put him back on his regular FiO2, and everything's groovy. So I really encourage you guys to just seek help for those kind of patients. Anyway, so the difference. Analyze, so it's now, you can see this is now finally up to 100%, but it took a while. And I'm going to take that off. Okay. Exhale minute ventilation, I already kind of told you about when we talked about blood gases. This is the total minute ventilation the patient should have. It's just a good thing to keep going about, and I think that's enough on that slide. Any questions so far? Is this helpful? Good. All right, so plateau pressures I was babbling about a little bit ago, talking about peak pressures, and we wonder what the plateau pressure is. All right, I just, as a therapist, come up here and I push this little button, and it does what's called an inspiratory hold. So the next breath is being held, no airflow is going in, and I can see that my plateau pressure is 20. Peak pressure was 21, plateau pressure is 20, perfectly normal lung. Okay, that's kind of a normal relationship. If, again, if I had an asthmatic, I might have peak pressures of 50, but I do a plateau because most of that air isn't actually getting down to the alveoli. It's just being stuck, getting through all the restrictions and stuff. I may have a plateau pressure of 20. That's somebody who has a lot of airway resistance. That wouldn't be an unsurprising thing to find. Again, not common in your patients because you don't have a lot of asthmatics who get head injuries, but they certainly can, but they're not in there for asthma, so their lungs are probably okay at the moment. But anyway, it's just a general reminder. Just kind of keep, if their pressures are higher, you want to know what they are, what the plateau pressure is. And I talked about lower tidal volumes. Any questions on any of that? I think I tend to talk ahead of my slides sometimes. I do apologize. Dyssynchrony, otherwise known as asynchrony. In other words, bad synchrony. There isn't synchrony between the patient and the ventilator. This picture here is just a mess. Okay, this is what pressure control, or PRVC, is supposed to look like, or pressure control, same thing. Supposed to have nice, pretty square pictures. This kind of stuff means, okay, here the patient is being nicely supported by the ventilator. Here, the patient's dragging the ventilator behind them. Okay, this is not what we want to have them do. They're sucking through so much, and I can maybe create this. It's really hard. It's hard. Yeah, maybe. So that's not a good picture, and the patient is pulling really hard and working really hard. We put them on the ventilator to decrease the work of breathing, not increase the work of breathing, right? So if you guys are, I don't know, titrating sedatives, your drips or whatever, and they did look like this, and then they start looking like that, well, the patient is not tolerating that wean and sedation, all right? Numbers might look great on the monitor, but look at this picture too, because this picture will tell you whether or not he's tolerating. Does that mean you can't wean the sedation? No, it just means call the therapist in, and maybe we can tweak the rise time, or maybe we can tweak the cycle off time, or we can adjust some things and maybe improve synchrony for the current level of sedation. Does that make sense? So we can't always, there's always going to be a limit to what we can do, or maybe we have to switch to pressure support or whatever. But dysynchrony is a real big issue, actually, for patients. It totally prolongs their length of stay on the ventilator, which prolongs their length of stay in the ICU. It actually affects overall outcomes. There's a couple good studies there that you guys can refer to if you feel like it. All right. Ugly pictures, not good. Pretty pictures, nice. We like those. All right. So how do I know when somebody's ready to be weaned? Well, the main thing you want to think about is, has the reason he got intubated significantly improved or not? Okay. Is his level of consciousness now, does his GCS above an 8, right? If it's less than 8, we intubate, right? Less than 8, you intubate. They can't protect their airway if it's less than 8. So, has the cause of respiratory failure improved? Do I have adequate PF ratio? At least greater than 150. I would say 200 myself, but I'm not an expert. The expert said greater than 150, so there it is. They know. pH should be greater than 7.25, I would think, if you're going to think about withdrawing respiratory support, yeah. Hemodynamically stable or on low dose pressures, and they can initiate a breath. That's always very helpful if you're going to try to wean withdrawal support. Optional criteria, you should have a hemoglobin greater than 7. You ought to be warm. And the mental status should be awake and alert or easily arousable. Now, obviously, in your unit, we do spontaneous breathing trials on people who have intact drives but aren't arousable, because we want to see if we just need to trach them or we need whatever. So that's obviously something that we do that would be different, and correctly so. But there's so much stuff on weaning out there, you could just drive yourself crazy. Just don't read anything like, I don't know, later than 2005. Strategies to facilitate weaning. I like this. All right, you want to obviously explain to the patient what's going on, which is good, and the family. Families don't need to stand at the bedside and take a deep breath. Just breathe, honey. Take a good deep breath. Take a deep breath. I just are you going to stay here all day and do that? Are you going to stay there at home when you're doing that? Because, breathing is a normal physiologic response. We're either ready to do it or we're not ready to do it. We don't need to be coached all day long about when to take a breath. Okay. So it stresses the patient out a little bit. So it's just better if the patient's ready to breathe, he'll breathe. If he's not ready to breathe, he won't, and we'll come back and try again another time. You do want to keep pain control appropriately maintained. For our weaning criteria here is to keep the RASS score -1 to 1, somewhere in that range if you're weaning somebody. It's good to keep a vigilant presence, because sometimes they just get tired of breathing through that tube and they will pull their tube out, and then we have to do all that extra paperwork. Okay, so we don't want to do that. I think you guys have the CPAP signs in your unit too, right? Patient on CPAP trials. Even though they're not CPAP trials anymore, it's close enough. All right. Avoid unnecessary physical exertion. Okay, so if you guys haven't done your morning care for the patient, don't start the breathing trial, okay? Or if you haven't done the morning care and they really want that breathing trial done, hold off on turning the patient and cleaning him up and putting on new gowns and bathing him until the trial's done, okay? Let's give the guy a break, give him every opportunity to pass instead of fail. So coordinate your plans accordingly. Try not to be doing busy work while they're just needing to breathe. Maximize physical environment, be conducive to weaning, temperature, noise, TV, whatever. Sometimes the TV's a good thing, sometimes the TV's a bad thing. Your room, probably a bad thing, generally speaking, I would think, but I don't know. Anyway, you guys know about this ICU pain and sedation toolkit? You guys aware of it? It's got really great information on particularly pain control and sedatives while on mechanical ventilation. I think it's a great tool. I love it. Anyway. Signs of weaning intolerance. Abdominal paradox is probably the biggest one. So if your belly's going the opposite direction of what it should, the patient's already showing signs of muscle fatigue, so that's a bad one. High respiratory rates, if they're consistently above 30 to 35, that's probably not a good outcome. If they're consistently above 30 to 35, their breaths are probably pretty shallow, and they would be doing what's called rapid shallow breathing, which is not a good thing to do. Level of consciousness changes from before the trial to during the trial. Obviously we'd want to stop that trial at that point because it's not going well. They get diaphoretic, they complain of extra fatigue, or they get really anxious, different things like that. Or if the blood gases or the SATs drop. Obviously these are not good things. On this ventilator, there's a button called Trends. It's my favorite button. You push this button and you can see the last 24 hours what the patient's been up to. Now, it's not going to look very impressive here because my ventilator hasn't been on an hour yet. However, if I'm doing a spontaneous breathing trial, I can see 2 hours straight. I can see what my respiratory rate and tidal volume have been running, and I can see how what my pressures have been doing. So I can see how nice and smooth that breathing trial was. During an SBT, pretty much it should be nice and even. You really shouldn't see wide fluxes in tidal volumes, some fluxes in tidal volumes, of course. So it's a nice picture, and you can look at it. This can be adjusted 1 hour to 2 hour, 1 to 3, so you can see the whole trial where. It just is like when the doctor asks, well, how was his SBT? And I don't know, I was in another guy's room for 20 minutes of it. I don't have any idea. You can call it up and look, and everybody can see a picture's worth 1,000 words. And then you can know how the patient was actually doing during his spontaneous breathing trial. And if he had gone apneic, these little ticks up here usually indicate that something different was going on. So anyway, it's just a nice thing to use to assess what your patient's doing. If you dig deeper, keep going, you can find, I hope, one more, I think. Come on. Oh my God. You gotta dig deep. Sorry, I'll get there. There it is. Something called SBI, Spontaneous Breathing Index. This is an old data that we used to do. That's never good. Oh, that's not good. That's not good. Okay, well, we're all just going to stay here for that. Okay. Just making that clear. I didn't bring my stuff with me. All right, so this thing called SBI is another index that you can look at. If the patient's breathing spontaneously, that number, you want that to be less than 100, pretty much. It's not showing you much now because there's really been not a lot of spontaneous breathing in the hour here. The other place you can find it will be right here. If the patient does spontaneous breathing, it shows up on this screen. It's really more of a number to trend, okay? So if you're looking at how the patient's doing during his SBT and you start to see his respiratory rate starting to climb maybe a little bit and tidal volumes maybe dropping a little, you might want to look at that number to see how much it changed over the course of the 2-hour trial. A 30-minute trial is sometimes all you need. 30 minutes to 120 minutes is really all you need for a spontaneous breathing trial. We just do a standard 2 hours here because that's just the way the protocol was written, but it does not have to last that long. And if you think it's in your patient's best interest not to, then we can bring the doctor to the bedside and say, look, let's cut to the chase on this. We know he's doing okay, and let's extubate. So anyway, so that's just another thing you can look at, or not. Let me turn this off. I think I'm pretty much done with this. All right, so if patient becomes apneic, I've already talked about the vent alarms on that. Backup ventilation being used. that will kick in. So it'll look like, go from this to this, which I've already kind of showed you, so that's good. Discontinuing ventilation versus extubation. Obviously, and you guys know this better than anybody else, patent airway, patent airway, patent airway. If they cannot protect their airway, we're not going to take that tube out, right? We can trach them, but we're not going to take the tube out. We can take them off the vent. We used to actually put them on blow-by, like we put a T-piece on, which is hook up to some aerosol in the old days sometimes, but that's, of course, really mean to do now that we have pressure support ventilation. We don't need to do that. Patients had to breathe through these teeny tiny tubes. Say that 3 times fast. But it's really hard work on them, right? So if they extubate, or you think they might be a likelihood of extubation, sometimes we can extubate right to high flow or extubate to BiPAP. I would actually recommend high flow over BiPAP any day because it's just better tolerated by the patient, and maybe then wean them off of that if we're not 100% sure they're going to successfully wean. But obviously, if you can't maintain an airway, we're not even going to deal with that. Okay, he also asked me to talk about alarms. So I'll talk about the ones that generally occur on this ventilator. The high pressure alarm goes off, okay? Causes. Anything that's going to cause an increase in airway resistance, whether the guy's biting the tube, or the guy's just got secretions, or maybe a lot of edema, mucosal edema in the airway, whether he's air trapping because he's a COPD and we've got him on too high of a rate, or the tube has migrated into one of the main stems, either the left or the right, most often the right, but never say never. It'll go into the left just when you're least expecting it. Obviously coughing, but that coughing is usually just a per breath event. Decreased lung compliance. You get a pneumothorax, which we hardly ever see anymore from the vent because we use much lower volumes than we used to. Fluid overload, you give them a bolus. Sometimes the fluid just loves to go around the lung and hang out in the interstitium, which decreases your lung compliance, and then your pressures can start to rise. Do you guys use mostly PRVC, or you switch into volume control? Mostly PRVC. Okay, so in PRVC, you'll see an alarm that says pressure regulated. Okay, that just means that the patient's lung condition has changed enough that the ventilator tries to deliver 400 tidal volume, right? It's approximately. That's what, based on the settings I've got plugged in here with a tidal volume goal of 400. It's going to try to deliver 400, and it'll go up and down on the pressure as it needs to keep that tidal volume goal around 400, okay? That's one of the benefits. It's the safest mode of ventilation. It's not perfect for everybody, but it's the best of both worlds, consistent tidal volume delivery and safe pressures, so we like that. But if the patient's lung condition changes and it's taking more and more pressure to achieve that tidal volume goal, it's going to eventually stop, and it stops at 5 centimeters below where I have my high pressure limit set. That doesn't really work. But if you're seeing that alarm, that just means I'm getting within the maximum operating. I can't go any higher than this unless you come and fix this. You either change my limits or you fix the patient, one or the other. But it's just letting you know I'm really not going to be able to maintain that tidal volume goal you want me to do. So that's what that is. And it could just be a suctioning thing. Might be. Could be the tube migrated. It could be any of those other things that I just said that might cause it. It could be changes in lung compliance. It could be, anyway, it could be any of those. So the vent's just saying, I really want to try to do what you want me to, but I can't. And it will stop the breath at that point. So that alarm, if we ignore it, can in fact lead to the next one going off, which is my low minute volume. All right. Low minute volume is simply setting that I'm not getting as much minute ventilation as I should. When I have the vent set, there's X amount of minute ventilation I expect. And typically I set my alarm around that because the patient wants to breathe over it, that's fine. But if it goes below it, then I know my vent's not operating correctly. And that's the main way I can know that. A lot of ventilators have a high pressure alarm and a low pressure alarm. And your low pressure alarm will kind of key you in if you have a leak or something. This vent doesn't have a low pressure alarm. This vent just has a high pressure alarm and a low minute volume alarm. So minute ventilation is the only way I'm going to know that I'm not getting the amount of breath that I'm supposed to be getting on the vent. All right. So causes would be anything that would cause a leak. If I got a cuff leak, or maybe I've got something came disconnected in the tubing. We don't use those humidifiers anymore, so they're not usually a problem, although they can crack. Those humidifiers can crack. You could have a leak somewhere, a subtle leak in the system somewhere. Leaks are usually visible. You can tell them on the graphics if they're there. But if the patient is in pressure support mode, it might just be that he has tuckered out and his efforts are no longer as good, and he's doing some rapid shallow breathing, but he's not maintaining the minute ventilation. Anyway, that's going on. We need to do something because ventilation isn't happening as it intended to happen, right? The other alarm that this has is a high minute ventilation alarm, which is the one that goes off when we're annoying the patients and turning them on their sides. All right, so that's usually just an annoyance thing because people don't like to breathe more than they're supposed to. If our CO2 gets too low in our head from breathing too high, we stop doing that. In general, not all your patients probably behave that way, but in general, they're not going to keep breathing that fast. So I don't really worry about that high minute ventilation alarm too much. And in general, I just don't. Your high respiratory rate is another one that's on there. Again, more important when you're weaning somebody. You guys know the critical heart rate? What if you had to say what the critical heart rate is for a patient, what is it? You don't want a heart rate ever above 140. I was told it was 140 because the heart doesn't have enough time to fill, so your stroke volume drops, right? Respiratory rate, you really don't want them higher than 35 in general because it's the same thing. You're not going to have enough time for gas exchange. You're not going to be working well. So in general, we want to keep respiratory rates lower than that. On a vent, full ventilatory support, you pretty much want it lower than 30. You shouldn't be have it set to be breathing that much faster than that, and typically we do. Unless you got your ARDS patients and trauma patients, and those times we go up to 35 on them, but that's for other reasons. Anyway, low minute ventilation. It's typically a leak of some sort or ventilator malfunction for some reason. So it's
I want to point out, I had a patient one time where the respiratory rate was on the vet, the actual showing like 50, right?
total rate?
The total rate. And then if you look at the patient, there's no way he was breathing 50.
Autocycling, yeah.
So, and it turned out to be something was wrong with the vent, but I was training someone at the time and they didn't recognize that this was actually a vent thing. So I just want to point out, so if you have a vent looking at, this is how the vent is saying how fast the patient's breathing, don't forget to look at your patient.
Yeah. Same thing with the, like I said, the monitors. I always counted on the monitor alarm, the respiratory rate from the monitor. I look at that a lot because if that's different than what's on my vent, because the monitor picks up muscle activity, right? So if my vent is doing what we would call autocycling, just triggering even though it's not supposed to be, that can happen. And if it's happening, that's one of the first ways that I would pick up on it, because my muscular rate, okay, that one, is different than what is happening here. Same way if the patient can't trigger, my muscular rate would be a lot higher and I wouldn't have anything, no triggering going on here, but I can see that he's trying to make an effort. So yeah, always look at the patient and match it to what's going on. You can just do it by hear and sight, and sometimes it's harder to, sometimes you gotta look real carefully to see which breath is coming first, the patient or the vent, but it's certainly something to pay attention to. Thank you. Those are the main alarms. I already demonstrated the apnea sequence, and I talked to you about pressure regulated. I don't want to hear it right now. So, general stuff on correcting blood gases. You guys probably know this. Like there it is. The PO2 is too low. You can either increase FiO2, but try not to go above 60. It's far better to increase your PEEP. Now, you guys work in the worst unit for me to just say increase your PEEP. Okay, I know. Don't just increase the PEEP. Neuroscience, obviously, because it increases interthoracic pressure, which impedes blood return to the chest. So that's going to cause some trouble. So you want to use that very judiciously. Different guys have different feelings on it, but higher FiO2s are also damaging to the body. So anyway, increasing the mean airway pressure is another way to do it. And we can do that with inspiratory times as well. If your PO2 is too high, then you just do the opposite of those other things. High CO2 kind of depends on what the cause is, okay? You can either increase your rates, you can increase your pressure support level. We generally don't increase tidal volumes necessarily because for the reason that we don't want to overstretch the lung. So typically it's just increasing the rate for the most part. Patients generally thoracidotic will be breathing over their own vent anyway. So when you do get a vent change from a doctor based on the blood gas, make sure that he's giving you a number that makes sense. If we're on a rate of 15, he says we'll turn it over to 20, but the patient's been breathing 22. Okay, that's not going to do any good. Okay, you got to go over what the total rate was, all right, in order to make a change on that. If its CO2 is too low, then you can do things, well, assuming he's breathing, you could try pressure support. Okay, if he's not initiating a breath, don't do pressure support because he has to do that. Otherwise, maybe dropping the tidal volume to more like 6, depending on what he's starting at. Dropping your rate if he's not breathing over the vent. Change modes, different choices. That's really pretty much it. Low numbers are low CO2s and high PO2s are good things to deal with. They're easy to fix. It's the other ones that cause all the trouble. Additional resources. There are so much information out there for you guys to read through if you want to, if you're just dying to know more about mechanical ventilation. Some of the handouts don't have this page. I did print extra ones on the counter. You can pick one up if you wanted to. The ones on the left are all about up-to-date. You guys are aware of up-to-date? Yeah? Great information on there, but oh my gosh. And that's like only the ones that I chose. There's so many different articles on there. HealthStream, there are 14 no, not CRCEs, that's our stuff, sorry. Nursing credits you can get all on ventilation. Different things on mechanical ventilation. You could amuse yourself endlessly while you're at home and go, oh, I think I'll get some education today and log on to HealthStream. Because you can do that from home, right? There you go. From HealthStream, yeah, you can.
We're not supposed to.
Why?
I don't know.
If you're doing voluntary continuing ed, sure, for your license, sure you can. Take advantage of it. It's free.
Just don't fill out a form paid.
You won't get paid. I mean, you don't get paid to do continuing ed, right? That's your license responsibility to maintain that. You're not supposed to do email. Lippincott's got a lot of stuff too.